mirror all the way in back? Yes, people are nodding yes. My name is Jeff Brosco. Welcome to Pediatric Grand Rounds. Before I start, I want to let you know that Ashira Klein, one of our wonderful students, is passing out a survey about transition to adult services. So if you wouldn't mind doing that for it, that would be great. It would help our team figure out how to improve services for young adults. All right, starting with our back row volunteers. What's the most common chronic condition of childhood? It accounts for the most hospital days, greatest number of school days missed, most expenses for medications. Asthma, right? And what percent of kids have asthma? 5, 8, depends, right? Okay, diabetes, type 1 diabetes. What percent of kids have diabetes? Need insulin? Nobody? No endocrinologist here? What's your guess? Carolyn, what's your guess? 0.1. 1 in 1,000 children has diabetes. 1 in 1,000 has sickle cell disease. What about liver transplants? What percent of kids need a liver transplant? About 1 in 500,000. How many of you have seen at least a child with a liver transplant so far in your practice? Nope. We don't have a transplant service here anymore? Dr. Lambert, raise your hand. If you look at the diseases of childhood, there are about 13,000 of them, almost all of which are incredibly rare. And you add them all up, it's about 5% of kids who have a serious medical condition that leads to any kind of impairment on their everyday function. And most of us in medicine learn in places like this, you know, the UM Jackson Hospital campus. And we think that 5% of kids have diabetes. We think that 10% of kids have stuff, when in fact the vast majority of children are healthy. When you look at the conditions of childhood and adulthood outside of medical campuses, it tends to be behavior disorders, developmental disorders, and it's at least 15 to 25% of folks have a significant issue with learning, behavior, getting along with others. And if you look at the outcomes of chronic conditions, many of them have important neurological, behavioral, and developmental outcomes. That's one big idea. The other big idea is what's the most important contributor to health of a person? What percent, or I'll change the question, what percent of what a doctor does contributes to the health of their patient? Like, if you want to know a person's health, it's about 30% genetics, it's about 30% behavior, about 30% environment, and what doctors and clinicians do accounts for about 10% of a person's health. So the other 90% happens a lot more in populations, happens a lot more with policy, happens a lot more in legislative decisions. I think a lot of us would see that the most recent bill passed on tax policy will probably have a much greater effect on people's health than anything any of us in this room can do in our office. We're really lucky today to have Andy Imperato as our guest speaker. Andy's a disability rights lawyer. He did his undergraduate degree at Yale, he trained at Stanford, and then almost by sheer luck, he ended up with Barry Zuckerman and some of the folks in Boston, and ended up doing disability rights law, trying to work out SSI, Social Security insurance for children and adults who needed to be able to get access to that. And then he worked with at the EEOC, the Equal Employment Education.
Equal Employment Opportunity Commission.
There you go. Andy can say it. Where he worked with a mutual friend of ours, Paul Miller, for some years in trying to make sure that people had equal access to employment. And then staff Tom Harkin, Senator Tom Harkin, and he'll tell you more about this in his work in legislative affairs. And right now is the chief executive officer of something called AUCD, which is the National Parent Organization for Mailman Center and the other 60-something centers like ours across the country. So Andy has expertise in understanding public policy and advocacy and disability. And as I tried to suggest in this introduction, those are in some ways essential to what all of us do in child health. And he's going to talk to us for about half an hour or so about some of his experiences. Then it'll be a chance for us to ask questions about disability and policy. So, any further ado, please join me in welcoming Andy Imperato.
Thank you, Jeff. This is my first time doing a grand round, so I'm excited to have the opportunity. And I just want to try to get a sense of the audience. How many people here are pediatricians or studying to be pediatricians? So a number, and then how many are working in some kind of a healthcare or clinical setting with children, even if you're not a pediatrician? Okay, so most folks here are focused on kids, which makes sense. This is pediatric grand rounds. And I will try to focus on policy issues that are particularly important for children with disabilities. I want to thank Jeff and Danny, the director of the Mailman Center. Danny just joined our national board, which I really appreciate because he's going to bring a lot of expertise and value to the board. The center here is one of 67 University Centers for Excellence in Developmental Disabilities around the country. We have at least one in every state and territory. Florida has two. There's one at the University of South Florida as well. And the Mailman Center was one of the original centers, is one of the largest centers, and has some of the most intelligent and creative and I think cutting edge folks in our network. So we benefit all the time nationally from the work that happens here, and the disability field benefits internationally from the work that happens here. So I'm really grateful to have this opportunity to talk to you about lifting your voices for policy. We used the term lift your voice because that was the theme of our conference this year, and it seemed to resonate a lot with our membership. We had about 900 people come to Washington in November for our national conference, and I think people are feeling like they're living through a period of disequilibrium. There's a lot of change happening politically. There's changes happening in technology. There's changes happening in climate. And I think in this time of disequilibrium, it is important for people to engage in the conversation, and in the context of children, to be a strong voice for children and for policy and practice that we know works well for children and families. So, you know, Jeff talked about my background. I self-identify as a second-generation disability advocate. I graduated law school in 1990, the year that the Americans with Disabilities Act was signed into law, and I'm part of a generation of professionals who benefited from having a civil rights law. I have bipolar disorder or manic depression, which I've been open about throughout my career, and I had my first serious episode of depression during my last semester of law school. So the timing was good with the passage of the ADA. And I think when we talk about the impact of the ADA, in 2015 we celebrated the 25th anniversary. President Obama had a big event at the White House. There were about 10 events in different federal agencies over the course of 2 weeks celebrating that anniversary. Sometimes we miss some of the intangible things, and I feel like one of the biggest things that the disability community in the United States has gotten from the ADA is the idea that we can be comfortable being out with our disabilities at work and not experience discrimination, and we can have pride around our disability identity, just like people may have pride around other cultural identities or their gender or their sexual orientation or whatever kind of makes them unique or whatever communities they feel connected to. That didn't happen because of the legislation, but the civil rights movement around the legislation also has supported the growth of a disability culture, we talked about that earlier, and a disability cultural identity. And you know, I think those of you who work with children every day, one of the opportunities you have in a clinical setting is introducing a parent and introducing a child to a concept of disability that doesn't scare them. And I think that was particularly powerful for me as I was starting my career. I was around disability advocates who truly believed that disability was a natural part of the human experience, a natural part of human diversity, and that it shouldn't in any way limit what I could accomplish as a lawyer, and it shouldn't in any way limit what other people can do in terms of participating fully in the community. For lots of parents, the first person that educates them about disability is a clinician. So I just wanted to share a story from my own experience. My wife and I were invited to speak to our oldest son's preschool class when he was 3. And the idea was, what do you do for a living and how does it help the community? It was called Community Helpers. So my wife came in, and she's a history professor at a college level, and she brought age-appropriate historical artifacts for the 3-year-olds and kind of got the 3-year-olds excited about American history. And the preschool teachers were surprised that a college professor could make history interesting for 3-year-olds. So the pressure was on when it was my turn to come and talk about what I did. And I worked at the Equal Employment Opportunity Commission for a little person, lawyer, Harvard Law grad named Paul Miller, who was a Clinton appointee. And I wanted to get across to these 3-year-olds that I was a lawyer and I did civil rights in the workplace, and that my expertise was disability civil rights. And somehow I felt like the concept of disability was going to be the hardest thing for the 3-year-olds to understand. So I decided to practice on my son at home. His name's Anthony Garrett. We called him AG at the time. And I said, AG, do you know what a disability is? And he said, yeah. And I said, what is it? And he said, I don't know. And I said, well, you know, like somebody who uses a wheelchair, who do you know who uses a wheelchair? And he said, Chris Griffin. He knew Christine Griffin because she worked with me at the commission, and when he would come visit me, she would have presents for him, so she was high on the radar screen. And then I said, or somebody who's blind and uses a white cane, who do you know who's blind? He said, Chris Kaczynski. Chris and I commuted to EEOC from Baltimore on the train, and sometimes we gave Chris a ride home on the train. And I said, AG, sometimes people have a disability, but you don't know from looking at them that they have a disability, and some people call that a hidden disability. I said, can you give me an example of a hidden disability? And without missing a beat, he said, like being a lawyer? So at that moment in his life, all the people that he knew that had disabilities were also lawyers. You know, some people might see that as a sign of progress, some might not, but it is a true story. So, you know, the main thing I wanted to share with you, and I really do want to have plenty of time for questions, is that children with disabilities and their families desperately need your voices in the policy process, helping to educate policymakers, educate the media, educate the public about what's working and not working in Miami, what's working and not working in the state of Florida, what's working and not working from a national perspective, and what's working and not working from an international perspective, because you have tentacles to lots of constituencies outside of the United States. And I think sometimes clinicians feel like, well, there are other people who will do that. You know, parents are the strong advocates for children. We'll just do our clinical work and let the parents do the advocacy. You know, adults with disabilities like me are out there, you know, storming Congress. They've got this covered. And I guess for me, it was really helpful at the very beginning of my career, working with Barry Zuckerman and his interdisciplinary clinic at Boston City Hospital. I immediately saw the value of having all these other disciplines thinking at a systems level about how to make things work better for low-income children and families in Massachusetts. They weren't just focused on the health issues, and I appreciate Jeff's point. They were thinking about how is Medicaid functioning in this system, and are there things that we can do better? The Supreme Court had just changed the definition of eligibility for the Children's SSI program, so I was working with them to explain to them what they needed to put in their letters to Social Security so that they were hitting the issues that Social Security cared about in terms of children being eligible for SSI, which brought cash into the family to help them address the issues, not just for the child, but for the whole family. So I think pediatricians naturally get this. I think folks who work with children naturally get this. I feel like the whole medical profession could learn a lot from pediatricians, because I don't think the advocacy should stop with kids. If you work with adults with a chronic health condition, you should be thinking about the systems level issues and the policy issues for the adults with those conditions, whether it's bipolar disorder or Parkinson's disease or whatever the condition might be. But I do feel like pediatricians are particularly adept at explaining to policymakers why something matters for a child and a family, and doing it in a way that doesn't come across as ideological or as, you know, kind of talking down to the policymaker. So I want to hit on some opportunities that I see for leadership for you all here in Miami in the policy arena at the national level, or opportunities that were created at the national level. First, I'm very inspired by the strategic goals that were developed here, and I was here 4 years ago when you had a strategic planning retreat for the Mailman Center, but they have established as one of their overarching goals addressing disparities at the intersection of disability and other forms of diversity. And I feel like that is an issue that is going to get more attention over time. Our country is becoming more diverse over time. I grew up in Los Angeles, and I feel like cities like Los Angeles and Miami have more sophistication and understanding how to deal with multiple cultural identities, multiple languages, and some of the unique issues as a clinician in trying to serve those communities but also the policy implications. If the vocational rehabilitation system is supposed to be going into high schools, serving kids with disabilities while they're still in high school, do the counselors who work for vocational rehab have the cultural and linguistic competence that they need to work in those settings? And is there something that you can do as clinicians to help build that competence? That's an example where I feel like your focus can help advance the disability field and get better outcomes. Another opportunity is a bill that Senator Harkin did on a bipartisan basis before he left office. He retired in 2015, but in 2014, the United States Senate and the House passed the Workforce Innovation Opportunity Act, which sets the policy for the workforce development system, including vocational rehabilitation. So under this law, for the first time, the state of Florida is required to spend at least 15% of their vocational rehabilitation dollars serving young people while they're still in school. That's a new requirement. It's a new expertise that VR, some states already had it, some states didn't, but every state now is required to serve kids. And I think those of you who are looking at adolescent medicine, like I know your department chair is, and looking at transition, it's worth thinking about, are we partnering enough with VR? Are we thinking about them as an important seat at the table at an IEP meeting? Is there something we could do to educate them clinically about what's going on for adolescents with autism or Down syndrome or any number of conditions? And I just think it's worth thinking about that as an opportunity here in the state of Florida. Similarly, we had a bipartisan reauthorization of the bill that was called No Child Left Behind. It's now called the Every Student Succeeds Act. And the compromise that enabled that bill to move forward was the idea that we are going to hold children, we're going to hold schools accountable for progress for children, and we're going to disaggregate children with disabilities and children from other diverse constituencies, but we're going to leave it up to the states to define what progress needs to occur. So instead of defining it at the federal level, we're going to define it at the state level. So in a state like Florida, how are you measuring progress for children with disabilities in the public school system? And again, I think in part because of Jeb Bush and his national leadership role on education reform, if Florida figures this out and can show that children with disabilities are getting good outcomes in the state, and you've come up with good metrics for what that looks like, that can have a ripple effect across the country. So that's another opportunity. And then the third one, which is recent from the federal government, is the ABLE Act. How many people here have heard of the ABLE Act? So this is a federal law that was led by Republicans, but it was very bipartisan, and Congressman Crenshaw, who was the lead Republican on the bill, is from Florida. But the concept in the bill was that parents are able to put aside money in 529 savings accounts for their kids to go to college. Parents of children with disabilities should be able to set aside money and get the same kind of tax advantage to do that can be used to meet the needs of their children as adults, healthcare needs, housing needs, assistive technology needs. It's very broad. And they'll have the same tax advantage to do that. So my understanding is Florida has passed implementing legislation to implement the ABLE Act. To me, what's interesting about the ABLE Act is you had a bunch of members of Congress who had children with disabilities who were leading the effort, including Kathy McMorris Rodgers, who's the highest ranking Republican woman in the House, who felt like our entitlement system was not creating the kinds of life opportunities that they wanted for their children as adults. So ABLE stands for Achieving a Better Life Experience. And my hope is that the ABLE Act is the beginning of a serious effort to make the biggest programs that support people with disabilities create more opportunities for them to participate in the mainstream of the economy, including by working. So the hardest issue that we're facing at the national level right now is this issue of the big dollar federal programs. The four largest programs that serve people with disabilities are Medicaid, Medicare, SSI, or Supplemental Security Income, and SSDI, or Social Security Disability Insurance. About $500 billion a year is being spent to support people with disabilities, children and adults, through those four programs. What do you have to prove to the government in order to be eligible for SSI and Medicaid as a corollary, or SSDI and Medicare as a corollary? They both have the same definition of disability. Does anybody know what you have to prove to the government in order to be eligible? So I'll give you the statutory language. It was written in 1956. Okay, so this is 1956 thinking. They say you have to have a medically determinable, and by that they mean doctors are important in this. You have to have a medically determinable physical or mental condition that's going to last at least 12 months or result in death that prevents you from engaging in substantial gainful activity. So most people, when they apply for disability benefits, they understand that they're proving to the government with medical evidence that their disability prevents them from working. And if you're unable to prove that, you don't have access to all of these supports that you need to live in the community, some of which are going to help you work. So you have to go through this front door of proving that you can't work in order to then turn around and try to use the work incentives that are very complicated that are built into the Social Security system and the Medicaid program to help you work. This is bass-backward policy. It's 1956 thinking about disability, and it's very, very hard to change the definition of disability because the CBO, the Congressional Budget Office, assumes that anything you do to make the definition more attractive will result in all these people coming in out of the woodwork. They call it the woodwork effect, and that the program is going to get a lot more expensive because it's an entitlement program. So if somebody's eligible, they're entitled to it. Vocational rehabilitation is not an entitlement program. We spend $4 billion building people's human capital and helping them get into the job, and we spend $500 billion on a program that forces people to prove that they can't work with medical evidence. It's just bad policy. So you might think, well, what can we do about that in Florida? I think the way that we fix that is by states innovating for the federal government a better way to support people with disabilities, showing what it costs, showing what the consequences are, and then using that as a basis for changing federal policy. This is an issue that governors can get excited about. They like the idea of spending money to support children and adults with disabilities in a way that produces better outcomes. And to me, that's the way it should be framed. So I do think there's an opportunity there. If you're looking for example, look at what the country of Australia did. People came together in Australia and said, our disability benefit system is broken. It's resulting in a lot of lost productivity because parents are having to stay home and take care of their adults with lifelong disabilities. They're not participating in the economy. We're spending money on things that don't make sense. And they completely reinvented their approach to supporting people with disabilities. So they now have something called the National Disability Insurance Scheme. They literally use the word scheme. It's not a negative connotation in Australia. But under this system, everybody starts paying into the system from the moment they start working. And then they use that money to support people with disabilities across the lifespan from birth. And they are trying to use evidence-based interventions at as early a stage as possible so that you get the best long-term outcomes for that person. Nothing in their definition of disability requires people to prove that they can't work. There's an expectation that people with disabilities will participate in the labor force to the best of their ability, and Australia does not want to limit that in any way. So I had an opportunity to hear a presentation on the Australian system. The fact that really stuck in my head was they're spending twice as much money now to support people with disabilities than they were when they started the system, and they're serving a third more people than were being served when they started the system. But because of this insurance model, they have enough money to do it, and they're not having to raise taxes, and it has very broad bipartisan support in Australia. So my hope is that we can learn from the Australian model. We can empower governors, particularly in this climate. States are more important now than they were in the past, although they've always been important. But I think we can empower governors to innovate in this area. And I do think pediatricians and folks who work with children and families could play a role in thinking about if you were going to redesign Medicaid and how it worked in a state like Florida, what would that look like? I know Jeff, in his political role, is in a process of looking at healthcare transformation. It's worth thinking about, are there lessons in that we could use to reform our larger federal entitlement programs? The last thing I want to just briefly touch on is based on my experience on the receiving end of advocacy when I was the disability policy director for Senator Harkin. What does effective advocacy look like? And a lot of this may sound basic to you, but I find it's important to just remind people. First, it's a marathon, not a sprint. Don't focus on whatever the thing immediately in front of you is, like the tax bill, or whether the government is going to stay open, or the repeal and replace effort on the Affordable Care Act. Focus on building long-term relationships with policymakers so that they see you as a source of unbiased information that they can go to when they're trying to get smart on an issue. And that happens a lot. A Hill staffer will call you and say, I need to get smart on higher ed and students with intellectual disabilities because we're about to have a hearing on it. If you can be the person they call to get up to speed quickly on an issue, and you can kind of deliver your knowledge in nuggets that are valuable to people who are drinking from a fire hose, which is the way that it works on the Hill, then people will contact you. And they need you to be available when they're thinking about the issue, which I know can be hard for clinicians that are pulled in a lot of different directions. But if you can prioritize as a system that you have the capacity to respond in real time, it may not be you, but there's somebody that can do that in real time, people are more likely to come back to you. Second point is learn how to make the staffers that you're talking to and the elected or appointed officials that you're talking to feel good about themselves when they're with you. The number one way to influence a policymaker is to make them feel good about themselves when they're with you. And one of the biggest mistakes advocates make is they go in with their talking points and they sometimes talk down to the staffer or the elected official, and they don't take the time to establish the rapport that then makes it more likely that that staffer or elected official is going to listen to you. And they may come into it assuming, well, these are doctors, they're going to be arrogant, you know, they've bought into all this liberal, you know, stuff. They read the New York Times, whatever. So if you could come in there and you know, treat them with dignity and respect, it's basically manners. But if you can have that kind of relationship, they're much more likely to listen to you. I also have already talked about this, the unique power of the clinical voice in this process. Policymakers don't hear a lot from clinicians. So when they do hear from a clinician, particularly a clinician that's not trying to somehow raise their salary, you know, because they do hear from clinicians about reimbursement rates. But to the extent that they're hearing from a clinician about how to make the world work better for children and families, they're much more likely to pay attention to that. And the last thing that I'll say, and I would say this no matter who's in the White House, it's critically important to cultivate Republicans. Everything that we're trying to do in policy for children, families, adults with disabilities is easier if we have Republicans who are championing it and supporting it. So the ABLE Act was championed by Republicans, and it's a good example of a law that is forward-looking, solves a real problem, and could be the beginning of a more robust agenda to really make our disability entitlement programs work better for children and adults with disabilities. So I'm going to close with a quote from Martin Luther King, who said that human progress is neither automatic nor inevitable. Even a superficial look at history reveals that no social advance rolls in on the wheels of inevitability. Every step towards the goal of justice requires sacrifice, suffering, and struggle, the tireless exertions and passionate concerns of dedicated individuals. You think about how the Mailman Center got started. It was people like Eunice Kennedy Shriver who would not stop pushing for a better world for her sister and for folks with intellectual disabilities. Dr. King said, without persistent effort, time itself becomes an ally of the insurgent and primitive forces of irrational emotionalism and social destruction. Dr. King said, this is no time for apathy or complacency. This is a time for vigorous and positive action. So friends, you are the dedicated individuals that Dr. King wrote about, and I am honored to be here with you today. Thank you. So I think we've got a good 20 minutes for Q&A, more or less.
Yeah.
And I'm going to call on people if nobody has a burning question. Yeah.
Besides Australia and that policy that you spoke about, are there other countries that you think have really great exemplary policies that have been implemented
Yeah, well, I think it's interesting to think about that in terms of which outcome are you focused on. So if you're focused on access to health care, there are certainly countries that are doing better than others. The Scandinavian countries tend to do better on a lot of access to human services. Where the Scandinavian countries have not figured it out is employment. There is no country that I'm aware of around the world that has a labor force participation rate for people with disabilities that is anywhere near the labor force participation rate for the general public. So Senator Harkin in his retirement is very focused on that issue. How can we accelerate progress globally? Right now in the United States, about a third of people with disabilities are in the labor force, and that was true when they passed the ADA in 1990. So we have not made any measurable progress on that issue. And if you think about it, well, how does that affect us as pediatricians? For folks that have childhood onset disabilities, what happens while they're children has a big impact on whether they're going to have success in the labor force. The best data that we have says that one of the most important indicators of success in the labor force is if you have a paid, positive work experience while you're still in school. This is for children with disabilities, but I'm sure there's an application of that for children without disabilities. So that's an example where I think the United States is a leader. Doesn't mean we have everything figured out, but if we can really show how to get better labor force outcomes, that could have a global impact because no other country has figured that out.
I have actually a follow-up question on that.
Yeah.
I have a daughter who has an intellectual disability, and as parents, she's very pretty. And it's the fear of supervision, that it's the vulnerability to sexual harassment, abuse, whatever word you want to work. That's clearly one of the problems with her working. We've had jobs in the past, and it's just how do we build into the system a way to make sure that that portion, it's very nice you come home and you tell me what happened. Not, as a parent, that's a big, big issue that I have.
Yeah, no, and I think...
I hate to say I wish my daughter wasn't pretty, because that's not true. But
yeah, no, I understand. I think that's a real issue that we're struggling with as a culture. Women with disabilities are more vulnerable to being abused, to being sexually harassed, to being sexually assaulted than women without disabilities. That's not unique to intellectual disability, but certainly it's very real for women and men with intellectual disabilities. I guess I would kind of throw that question back to you, because as a parent, I know I'd be thinking about what kind of a work environment is this? Are there people in the work environment that are going to be on the lookout for my daughter and be a natural support for her if she's in an uncomfortable situation? What kind of training has she had that's accessible for her? So if she gets a weird feeling, she knows what to do about it. But you know your daughter better than I do. So I guess I would throw it back to you. What would you like to see? Like, let's say she was coming to work at AUCD. What would you like to see in place at AUCD that would make you feel better?
Want the answer?
Yeah.
It has a lot to do with the commitment of the people who are supervising to watching.
So you as the parent want to have a relationship with the supervisor where you have a trusting relationship and you trust that they're going to be on the lookout for your daughter.
And that's not so easy when you're trying to
Step back.
Let's say
Yeah.
best buddies,
Yeah.
right? The job she's had. We've had situations that was good and the management changes, and then, it's sort of hard. I mean, there isn't always the commitment of the place to actually understand that's part of what hiring her is about.
I think another kind of piece in the puzzle for a lot of folks with intellectual disabilities, your daughter may not need this, but a lot of folks with intellectual disabilities have a job coach that's supporting them at least initially, and then sometimes they fade into the background. One of the things that job coach can be doing is establishing a rapport with the supervisor and creating, kind of a safety valve if there is a problem, that the supervisor's been educated and they're on the lookout for it, and they have the kind of relationship with the employee that the issue is likely to get surfaced. I don't think there's a simple answer to that, but I appreciate that that's an example of a barrier that makes some parents not want their kid to participate in the labor market. And there are other barriers that make some parents feel like, their top priority is for their kid to be safe. So some parents, are advocating for things like gated communities where autistic adults can live and they know that their kid is going to be safe in the gated community, or some have argued for farms where everybody on the farm is either a paid staff person or somebody on the autism spectrum, and it's giving them something to do in a controlled environment. A lot of disability advocates are concerned about those models, in part because it's in those segregated models where abuse happens, including sexual abuse, because there aren't a lot of people there to keep an eye on what's going on. So it's complicated, but I appreciate that safety issue is a real issue. Certainly it's an issue for parents of daughters who don't have disabilities as well, but it has kind of added sometimes concern around intellectual disabilities.
You mentioned in the beginning that one of the things that the physicians can do is to provide a non-fighting picture to the parents about the disability. You mentioned that it could be like a natural condition of humanity, right? But how the physician, I'm not a physician, but we work with a lot of families, serving them. So how we can do that?
I mean,
because it is.
Yeah, and I would love other people here to chime in because you do it every day. I mean, from my perspective, part of it is your nonverbal communication. When you're talking to a parent about autism or about Down syndrome or about Rett syndrome or whatever the condition is, are you talking about it like the kid is about to die? And is that your nonverbal communication, or are you talking about it in a way that I have something to talk to you about. I know this is going to, come as a shock, but I want you to know we're here to support you. There are lots of families all over this community that have experience. Some of the families say this is the best thing that ever happened to their family. Trying to present it in a way where they're not thinking that this is the worst thing that could have happened to them. So some of it is nonverbal communication, and some of it is all the other stuff that you say along with the diagnosis. But I'm wondering, Jeff or Danny or other folks, other thoughts in terms of how you present this information to families where they are kind of able to understand it in context.
Well, just one quick thing is that there's no doubt that in our medical curriculum, we spend so much time learning about basic science and relatively little learning about the skills of communication. And this is slowly changing. And so it's becoming a much more important part of our medical student and resident curriculum. And so we spend a fair amount of time talking about things like how do you deliver bad news, what are the circumstances for it, what's the language you use. So I think, Nancy, that we're moving in that direction, but I think probably everyone in this room would agree that our education system is still weighted heavily toward learning science and not nearly enough for learning communication skills. We're heading in the right direction. It's recognized as important.
But I also think it's interesting to think about the interdisciplinary team and who on the team can provide some of that information in a way that puts it in context. It may be that the physician is giving medical information and answering medical questions, but there's somebody else on the team who can talk about the family support resources that are available for that family and kind of round out the information. It doesn't always have to be the physician, but it's important to have somebody on the team who can do that. Other questions or comments? Yeah.
So one of the things you talked about a little bit, Andy, is about how to actually, when you're meeting with a elected official, when you're meeting with a staffer, you kind of give a couple quick things. But I've heard you talk at length more about this before, and how sometimes you do your homework ahead of time to find out who this person is. Can you tell us a little bit more about how you would approach a Hill visit or Tallahassee visit?
Sure. Well, I'm going to talk about your senators because I know more about your senators than I do about your House delegation. But this would be the kind of things that you could find out about any elected official. Their committee assignments matter. So Senator Nelson is on the Finance Committee, which is the Senate committee that has jurisdiction over Medicaid, Medicare, SSI, SSDI, and taxes. Pretty important committee. The chair of the committee is Orrin Hatch from Utah. The ranking member is Ron Wyden from Oregon. Your senator is a senior member on that committee. So if you're in a meeting with Senator Nelson or his staff, the first thing I would do is say, thank you for being such a strong champion for the Medicaid program, for Medicare, and for the Social Security disability program. These programs create a lifeline for our patients. Really appreciate your leadership. And then you can pivot to whatever the issue you're talking, but don't forget to thank him for that. Senator Rubio is on the Appropriations Committee. He's also on Armed Services. He's also on Intelligence Committee. Appropriations is critically important. So if you're happy that LEND got funding in the budget process, the Appropriations Committee played a role in that. So I would be thanking Senator Rubio for the funding for LEND, which the president tried to zero out, but Congress put the money back. So I try to start with something real that they did that you genuinely appreciate, and then pivot from that to whatever the issue is. You'd be surprised how few people know the committees that their elected officials are on, or know kind of what their policy priorities are. And again, if you're working with a national organization that's giving you talking points, it could be the American Academy of Pediatrics or AUCD or any other group. If all you do is just go through your talking points and don't take the time to recognize that person's kind of leadership role and things that they've done, it's just a missed opportunity. The flip side is what you do after the meeting. And again, it was very, very rare when I worked for Senator Harkin for me to get a thank you note from anybody who I met with, whether they were from Iowa or a national organization. If I did 20 meetings, I got one thank you note. So to the extent that you actually take the time, it could just be an email to say, I know how busy you are, I really appreciate the time, and here's a link to 3 of the things that I talked about, and let me know if you have any questions. You know, those little things make a big difference. Sorry, yeah.
Thank you for coming to visit. Learned a lot from your experience. Can you talk a little bit about, like, as a faculty member or staff or student, how you would navigate the fine line between perhaps lobbying and advocacy?
Sure. So if you're on a federal grant, you are not supposed to use federal dollars to lobby. And lobbying means telling somebody how to vote on an issue. So if you're working on the tax bill, for example, you shouldn't be using federal dollars to tell Senator Rubio to vote against the tax bill. Most of what we do with policymakers is not lobbying. It's, you know, like if we go up there with our LEND trainees and explain to them what LEND is and explain to them why LEND is important, that's not lobbying, that's educating them about a federally funded program that we participate in, and this is the impact that it's having in Florida. That helps them make good decisions as a policymaker as they're thinking about funding for LEND, or, you know, learning from the interdisciplinary nature of LEND to promote the value of interdisciplinary training. So the vast majority of what we do when we interact with policymakers is not lobbying. Senator Rubio is not likely to care what I think he should do on the tax bill. He's going to make up his mind on that for lots of reasons. He's under a lot of pressure to support whatever the party platform is on that issue. But he is going to care about what's happening in Miami for children with disabilities. And if there's a model program in Miami that's serving children with disabilities, he's going to want to know about it. So for me, a lot of what you do is about just letting them know what's happening in their home state or their home district, why it's important, and that you're a resource for them. If they're trying to understand, you know, what is going to happen to the Medicaid program as a result of, you know, big changes in, like, let's say you have a managed care implementation strategy for Florida, and they want to understand how are we going to measure quality in managed care. You guys have a lot of information that's going to be useful to them as they're tackling that issue. So to me, the best place for you to be is a source of information, a source of data, a source of stories that can put make issues a human issue. It's not, they don't need you to tell them how to vote. They can figure that out. And I think a lot of people, again, make the mistake to immediately go to, this is how you need to vote, as opposed to, this is what I know and I want to be a resource for you.
As a follow-up to that, how do you let them know that you are a resource for them? Right.
So part of it is kind of paying attention to their ecosystem and trying to become part of their ecosystem. Most policymakers have long-term relationships, and those are the people they most go to for advice. So if Senator Rubio, is part of a faith community and you're connected to that faith community, that can be a way for you to start a connection and become part of that ecosystem. Again, the goal is not to kind of turn him into whatever kind of politician you want him to be. It's for him to know that there are real issues for children with disabilities in Florida, and he can be a champion for these children if he takes the time to get educated. I think it's a great idea to invite your elected officials to visit the Mailman Center. One of the things I love about the LEND program as an opportunity is invite your elected officials to come and talk to your LEND trainees about leadership. because they all think they're an expert on leadership, and they don't have to learn anything about disability. They could just come and talk about leadership, which is part of LEN. So that's a natural opportunity to try to get a line of communication going. Obviously, if you're at the AUCD conference once a year, taking the time to stop by and meet with your congressional delegation or key staff is a good way to remind them once a year that you're there, and then that relationship can be built. I just visited the Wyoming Youth Said. They meet with Senator Barrasso every time they come to Washington. Now, part of that is because it's a small state. Florida, you're not going to have the same kind of access to your senators as Wyoming is. But I thought it was great that he's become a big champion of their ECHO platform that they use to do communities of practice, and he's really learned a lot about it, in part because they meet with him once a year. So you might be meeting with a staff person because the state is so big, the staff still matter. But some kind of regular contact is a good way to build those kinds of relationships. Yeah.
Andy, just to fill in on that, we work really closely with the University Government Relations Office. We have 3 primary people in federal, state, and local areas. And we routinely bring members of our congressional delegation as well as state folks to visit us in the mailman center every year. There's usually 3 or 4 visits each year. The other piece that's good is think about meeting folks, speaking to them when it occurs coincidentally. I have a great relationship with all of our South Florida congressional district because there is a 4:55 American Airlines flight that leaves Washington on Thursday afternoon to Miami. And they're all on it. And so we share pictures of our kids over the years, and we chat about how long the lines are to get on the airplane. And so what happens is when I call, they know who I am. It's a personal relationship, as Andy said, as much as it is that formal relationship.
Yeah. So I think we're about out of time.
But I want to follow up on that, because you've also pointed out that some of us get upset when a legislator votes a way we don't like. You've talked about how you need to separate that out, and they can be with you on some issues.
Well, that's why I said it's a marathon, not a sprint. You know, I'll give you an example. You can imagine our center in Utah, they have a new director who's very frustrated with how Senator Hatch led the effort on the tax bill, and is now saying that we don't have money to reauthorize the CHIP program, even though he had been saying that this was a priority. He wrote a letter over the weekend that was very, very harsh. And luckily, he showed it to some of his staff for feedback, and they convinced him probably not a good idea to send that letter. It was probably therapeutic to write the letter, so I don't think that was bad. But sending it is not a good idea, because you have to be able to work with Senator Hatch on the next issue. And if you're going to destroy the relationship over one vote, you're doing a disservice to the constituencies that you work with and your center's long history with that member. You can, write a respectful letter that says, I'm disappointed, but then you need to be able to pivot to whatever the next fight is. And you need to always pay attention to preserving the relationship. And I'm just saying that is what good advocacy looks like in Washington, but I'm not saying that it's typical. It's much more typical for people to get really angry and to kind of paint somebody as the demon, and then have a really hard time influencing them on another issue.
Thank you very much, Andy.
Yeah.